very good afternoon to one and all. Today I will present two interesting cases and my presentation is titled Fiery Eyes Can Sometimes Be Scary. So the objectives of today's presentation are to report about the varied clinical presentations of carotid cavernous fistula or red eye shunt syndrome, which can lead to an initial diagnostic dilemma, and to portray the role of an ophthalmologist in the diagnosis of CCF. So my first case is a 62-year-old female who presented to us with gradual painless diminution of vision in both eyes for distance and near since 2 years. She also complained of gradually increasing redness in both eyes since the last 1.5 years and was diagnosed as ocular hypertension in both eye elsewhere and treated with topical agents. But there was no satisfactory outcome. Instead of that, her redness has increased since the last 4 to 5 months. She also complained of progressive inward deviation of the eye since the last 3 months. There was no history of any trauma or systemic comorbidities in the patient. Her best corrected visual acuity in both eyes was 20/80 parts N12 and her color vision was diminished. The intraocular pressure was recorded to be 26 millimeters of mercury and 24 millimeters of mercury in the right eye and left eye respectively. The antecedent showed severe congestion along with dilatation and tortuosity of the episcleral vessels along with a senile cataract. So on the strabismus workup, we can see she had a 45 prism diopter of esotropia for distance and near along with a -3 abduction limitation in both eyes. The dilated fundus examination showed a normal disc with 0.4 cupping in both eyes along with features of resolving CRVO. So we ordered MRI brain and orbit with contrast, which showed a dilated and tortuous right and left superior ophthalmic bends along with a bulky bilateral cavernous sinus, which was suggestive of a bilateral CCF, which was also confirmed on MRI brain and orbit with contrast. So our final diagnosis was both eyes acquired esotropia with external ophthalmoplegia and CRVO in CCF, which was initially mimicking ocular hypertension. The patient was referred urgently to interventional neuroradiologist and neurosurgeon for further management. Coming to my second case, she was a 34-year-old female who complained of forward protrusion of the right eyeball since 1.5 months, which was accompanied by headache and vomiting. She also complained that she had a horizontal binocular double vision along with inward deviation of the right eyeball since the last 1 week. There was no history of any trauma. Her vision, color vision, IOP all were normal, except the pupil was mid-dilated and fixed in the right eye. She had a proptosis with resistance to retropulsion and there was episcleral venous congestion in both eyes. She also had a 50 prism diopter of esotropia on prism alternate cover test for both distance and near and a -2 abduction limit. The CT scan of the orbit, which was showing a bilateral bulky extraocular muscle with fusiform enlargement of the recti and proptosis. So we came to a provisional diagnosis of acute thyroid eye disease and did the thyroid profile, but it turned out to be euthyroid. As the CAS score was active, so we treated the patient with 3 doses of IVMP followed by oral steroids, but to our surprise, there was no improvement. So at this visit, we ordered MRI brain and orbit with contrast for the patient, which showed the features of bilateral CCF, which was also confirmed on MRI brain and orbit with contrast. So our final diagnosis was both eyes acquired proptosis, esotropia with external ophthalmoplegia and CCF, which was mimicking active thyroid eye disease. Coming to the review of literature, CCF is an abnormal vascular communication between the cavernous sinus and the carotid arterial system. It can be either direct or indirect. Spontaneous or indirect CCFs can occur in the setting of the systemic diseases. Red eye shunt is a congestive manifestation in the anterior draining CCF which affects the superior ophthalmic vein. Our patient had no such systemic diseases. We got all the history and all the tests, and so it could be either idiopathic or because of the genetic predisposition. So carotid cavernous fistula should be included in the close differentials of an atypical red eye presenting in patients with corkscrew basals, proptosis, raised intraocular pressure, acute strabismus and external ophthalmoplegia. To conclude, many patients with CCF initially present to an ophthalmologist with minimal ocular signs and symptoms, so it can lead to a misdiagnosis or misdiagnosis. The crucial role of an ophthalmologist lies in making a presumptive diagnosis, to revisit history again and again, to re-examine and order tailored investigations so as to cleanse the confirmatory diagnosis and enable the timely management. Thank you.
Thank you again. A very interesting case. Both cases extremely interesting to having spontaneous CCF. Even minor trauma or something was not there because
no, the patient didn't give any history of even trivial trauma.
Hypertensive? They were not hypertensive.
No.
So
all the systemic parameters were normal in this patient.
Okay, so those are definitely very unusual, and of course that reduces the confidence level in the diagnosis or even attempt to. But yeah, as you've rightly pointed out, that proptosis or minor proptosis even minor limitation of movement or congestion, very specifically dilated vessels or very corkscrewed kind of vessels. These are the ones that give rise to suspicion. But yes, in such a setting, it can be a challenge to come out with that. And even a small flow CCF can be difficult to pick up also.
Yeah,
So
mostly in dural CCFs or low flow CCFs, they present like this, as
yeah,
compared
so
to, as opposed to the high flow CCFs.
yeah, high flow CCFs not such a challenge. It's the low flow ones with very minimal symptoms, very minimal signs to pick up, which would be, and even investigative wise, it can be a challenge. So sometimes you really need investigations in detail to be
Yeah,
able to pick
and
that
very
up.
often they present to the ophthalmologist
Yeah,
at the
which
first
is
phase.
yes.
So it's a very crucial role.